department. She graduated from Semmelweis University in Budapest and worked at the University Teaching Hospital in Budapest before she moved to the US to complete her neurology residency at George Washington University. She then completed a fellowship in cerebrovascular disease at Beth Israel Deaconess Medical Center. She's been a stroke director at multiple other institutions, followed by stroke recovery research at the National Rehabilitation Hospital, and has received multiple grants for her research. She then completed her neuroimaging fellowship at Houston Methodist and is now director of the stroke recovery program.
In this lecture, I will summarize the main plasticity mechanism, temporal changes, and plasticity model used in CNS stimulation paradigms. Then we will review recent advances in CNS stimulation techniques. There are short-lived windows of opportunity after stroke in mature animals that are similar to early developmental periods of heightened neuroplasticity when the neural circuitry is particularly responsive to external stimuli. Within days after neuronal injury, rats showed time-sensitive increases in axonal sprouting, neuroglio and angiogenesis, dendritic branching peaking 2 to 3 weeks post-injury, followed by behavioral-dependent pruning of newly formed dendritic arbors. Intensive motor training provided to rodents within such periods has been shown to restore full motor function. However, if training was delayed to day 30, this benefit faded. Most interestingly, Zieler and colleagues demonstrated in 2016 a paradoxical motor recovery from a first stroke after induction of a second stroke that was thought to be due to reopening a neuroplastic window that had been closed before. Several recent studies have demonstrated that histone acetylation in the adult brain through epigenetic remodeling of the chromatin structure reopens critical periods like plasticity in adults. Importantly, this period of increased plasticity can only be translated into behavioral gains if training and practice takes place during this sensitive time period. Due to these time-dependent changes, all neurorehabilitative interventions should be evaluated in the context of the underlying neurophysiological state. For example, the vectors and avert trials evaluated very early mobilization and found that high-intensity training days after ischemic stroke may worsen outcome, while high-intensity long-duration training in the chronic phase may be needed for improving outcome. The CPES trial aimed to define this malleable time period after stroke. 72 individuals were adaptively randomized to receive 20 hours of extra therapy over standard care in the acute, less than 30 days post-stroke, subacute, 2 to 3 months, or chronic phase, more than 6 months after stroke, or in the control group. Surprisingly, the subacute group improved most, with clinically significant benefit. The acute group's improvement was statistically significant, but was slightly less than the minimal clinically important difference. Several models have been postulated over time. The first was the interhemispheric competition model that was based on the interhemispheric inhibition observed with TMS. According to this theory, the damaged hemisphere is not able to inhibit the other side and suffers from extra inhibition from the non-lesion hemisphere. Restoring the balance by increased excitability of the lesion hemisphere and or decreasing the excitability of the non-lesion hemisphere is therefore desirable. However, in several studies it seemed that the contralesional hemisphere may have beneficial effects as well when vicarious recruitment from the non-lesion hemisphere drives the improvement. The bimodal model combines these two prior models, adding that while the interhemispheric rivalry model works well for smaller structural damage, more severe stroke tend to follow the vicarious model. Lastly, recently there have been a few studies that use a network effect to target the stimulation. Synchronized networks can be influenced through any of the nodes of the system. Therefore, a distant stimulation site might be used to target a deep location, for example, if it is part of the same network. In 1950, neuropsychologist Donald Hebb proposed the rule that neurons that fire together wire together. Hebb's rule provided a theoretical foundation that homosynaptic and heterosynaptic activities facilitate synaptic formation and consolidation during motor rehabilitation. Neuroplasticity could be augmented through rehabilitation strategies such as basic task-oriented training. However, task-oriented training alone cannot effectively alleviate motor impairment and restore motor function. Unlike pharmacological therapy, electrical stimulation or magnetic stimulation provides a more targeted intervention to damage neural circuits, resulting in potentially better functional recovery for patients with motor impairment. Typical stimulation modalities for post-stroke motor restoration are demonstrated here. Transcranial electric stimulation and peripheral stimulation are not new technologies. These have been around since the 1960s. Slightly later, TMS and TENS and deep brain stimulation was developed. Some of the newest methodologies are spinal and cerebellar stimulation paradigms and VNS for stroke recovery. Recently, a high-definition TDCS was introduced that is able to produce a more focused stimulation. Interesting and potentially more effective variants of TDCS, such as transcranial alternating current stimulation or transcranial random noise stimulation, is being tested now, just to name a few. The recent advent of closed-loop EEG TDCS and EEG TMS helps alleviating some variability in the responses and provides new insight in network effects. We will first discuss vagus nerve stimulation paired with motor training. This is known to enhance synaptic reorganization after stroke through the release of plasticity-promoting neuromodulators such as acetylcholine and norepinephrine. Rats that receive VNS paired with motor training, indicated with the red bar, after stroke demonstrated a significantly greater increase in corticospinal tract connectivity to rehabilitated muscles. Corticospinal tract connectivity originating in both the ipsilesional and contralesional hemispheres was increased. These findings indicate that VNS drives large-scale reorganization in motor networks after stroke, which may underlie recovery of function. VNS paired with rehabilitative training significantly improves recovery of forelimb motor function in cortical, subcortical, acute and chronic ischemic strokes, and after hemorrhages. The investigators titrated the electric current 0, 0.4, 0.8, and 1.6 milliamp, and surprisingly found that higher intensity stimulation was not found to be more effective than 0.8 milliamp. In fact, they found minimal, if any, effect of both lower and higher electric current. In the clinical trials, the device acts as an implanted pacemaker for the vagus nerve, where the stimulator is implanted under the skin near the clavicle, and the wires are tunneled to the left cervical segment of the vagus nerve to encircle it with electrodes. For blinding, patients first received a tickle of 4 predefined stimulations, intensity ramped down from 0.8 to 0.4 milliamp at the start of each session, followed by appropriate stimulation parameters for each group. The active group received 0.8 milliamp and the control group received 0 milliamp. Participants received 6 weeks of in-clinic therapy, 3 times per week, total of 18 sessions, followed by home exercise program. All 3 clinical trials used a 6-week outpatient therapy in mild to moderate severity strokes. The first 2 studies were small, that was followed by a pivotal multicenter trial of more than 100 patients. Except for the first trial of Dawson and colleagues, the other two were double-blind trials where both groups had VNS implanted. Response rate and effect size was double in the active stimulation groups of each study. Number needed to treat was 4.3 for vagus nerve stimulation to have benefit. Study-related adverse events were generally mild and reversible, most related to surgical implantation and post-surgical pain. The effect size is approximately double with the stimulation in all studies. The impressive results led to the approval of the device by the FDA as a breakthrough device in stroke recovery. Transcranial direct current stimulation is a non-invasive battery-powered device to deliver low constant direct electrical currents to the head to stimulate specific parts of the brain. There are two types of stimulation with TDCS, anodal and cathodal stimulation. Anodal stimulation acts to activate a neural circuitry, while the cathodal stimulation inhibits and reduces neural activity. Although TDCS is still an experimental form of brain stimulation, it potentially has several advantages over other brain stimulation techniques. It is cheap, non-invasive, painless, and safe. It is also easy to administer, and the equipment is easily portable. The most common side effect of TDCS is slight itching or tingling on the scalp. It is approved in the EU for the treatment of pain and depression. Currently, TDCS is not FDA-approved treatment, but used as off-label clinical application to improve stroke recovery in several academic centers in the US. TDCS is evaluated as neuroprotection in acute ischemic strokes and as add-on therapy for stroke recovery currently in approximately 300 studies registered on clinicaltrials.gov. In a recent publication of evidence-based guidelines and secondary meta-analysis for use of TDCS, Fragni and colleagues found that the effect sizes for both subacute and chronic stroke patients were similar, approximately 0.5 when not used with robotics. TDCS is probably effective in chronic stroke patients when not used with robotics in all three testing paradigms: anodal ipsilesional, cathodal contralesional, and bilateral stimulation. However, it is not effective to enhance robotic therapy, or level B recommendation. TDCS is probably effective in subacute motor rehab. Level B recommendation for both anodal ipsilesional and cathodal contralesional TDCS when not used with robotic therapy. Bilateral TDCS received a level C recommendation. In the same publication, TDCS was found to be possibly effective to treat aphasia. All modalities received a level C recommendation. Magnetic stimulation options in addition to the most well-known transcranial magnetic stimulation or TMS. The FDA has designated an AI-powered electromagnetic field therapy technology as a breakthrough device in January 2021 based on 25 patients' results. Using EEG brainwaves, a proprietary machine learning algorithm translates this into a frequency-tuned low-intensity electromagnetic field to enhance plasticity. A pivotal RCT called Imagine is underway that is testing 150 patients over 9 weeks, 5 times per week for 1 hour therapy. Primary outcome measure will be the MRS. A novel multifocal magnetic stimulation method invented here at Methodist Hospital by Dr. Santosh Halapar and Henning Voss, named transcranial rotating permanent magnet stimulator, allows simultaneous stimulation of multiple areas of the brain and yet allows free movement of the patient, making physical therapy easy to implement. Dr. David Chu led a phase 1/2A double-blind sham-controlled clinical trial, and as a result of the success of this trial is assembling a multi-center clinical trial to test the efficacy of this promising approach. Transcranial magnetic stimulation, where electromagnetic pulses in the stimulator trigger small electric currents in the brain, has been FDA approved for treatment of drug-resistant depression, obsessive-compulsive disorder, and anxiety disorders. It has been evaluated in approximately 300 stroke clinical trials. Of those, 80 are currently recruiting or about to start to recruit subjects. Although several paradigms resulted in clinical improvements, routine use of a specific paradigm of stimulation cannot be recommended yet due to the significant level of heterogeneity of the studies in terms of protocols and outcome measures. A recent systematic review and meta-analysis found TMS effective in changing neurophysiology in paradigm-dependent manner. Spinal electric stimulation is experimental at this point. Activity-specific dorsal root spinal cord neuromodulation rapidly restored trunk and leg motor functions after complete paralysis in 3 patients with complete spinal cord injury. At our institution, Dr. Stoyenko and his team is applying a similar non-invasive technology after strokes in an ongoing study. The main goal of this study are to merge the therapeutic effects of upper limb robotic exoskeleton and spinal neuromodulation technologies within a single protocol to discover the underlying mechanisms of this approach in regaining motor function after stroke. In summary, mechanisms and models of plasticity are time and severity dependent. Plasticity enhancing options are increasingly approved and incorporated into everyday practice. Thank you for your attention, and these are my references.